Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. Today we're going to talk about the skin. The skin is the largest organ in the human body and can be subjected to a lot of stress, especially during this time of the year, where radiation from the sun can cause some significant damage. There's also several types of diseases and skin cancers that can develop, and we're going to learn about all these conditions today. Our guest is Dr. Sarah Cannon. Dr. Cannon is a board-certified dermatologist, and she works at the Dermatology and Skincare Center in Red Bank. Dr. Cannon, welcome to the show.
Hi, thanks so much for having me.
So tell us about your background and how you got started in dermatology.
Sure. So I'm originally from Philadelphia and trained in Jefferson and Philadelphia as well. So been living over here in New Jersey for several years, but practicing at Dermatology and Skin Cancer Center for the past 3 years or so. So It's been really great being here.
So why did you get so interested in dermatology during your medical career? What was the impetus there?
Sure. So in medical school, getting to rotate through all of the different areas of medicine. Dermatology is just such a great field for being able to dive into multiple things. Procedures, work with your hands, have great patient contact and seeing multiple patients throughout the day and kind of learning about them. And I just found the skin interesting.
Awesome, yeah. There's, especially during this time of the year with the sun and the effects of the summer sun, how strong it is. We know that it can be very damaging and cause some skin cancer. So let's start off the show with some of the skin cancers and what's involved in terms of the screening process and the diagnosis. Maybe kind of take us through how do you screen someone for skin cancers?
Sure. So that's really a lot of what we do throughout the day, throughout the week when we're doing general dermatology and taking care of patients on a regular basis is skin cancer screenings. There is no set recommendation for the average person to have a yearly or 6-monthly or every 2-year skin exam. So we really base that on patient risk factors. When we see someone come in, we look at the amount of sun damage, their sun history, family history, things like that to help us kind of guide how much we see them. So for skin cancer screenings, most people come to us without history of skin cancer, and we basically check you from head to toe. We check your moles, we talk about sun protection measures to take throughout the summer months and throughout the year to protect the skin. And if we detect things, we're able to take biopsies and treat them. So a typical skin exam, you would come into the office and we basically go from head to toe, checking all areas of the skin, hair, nails, and take care of any concerns that a person might have. And if there are any concerning lesions, that's where more might be done. And we see a lot of patients with skin cancer history in this area especially as well. So those people are seen a little bit more frequently.
So in terms of the risk factors, is the history more important than like their skin type, like a fair skin or somebody that may have red hair and freckles, or are those all equal risk factors? Or?
So they're not necessarily equal. There can be kind of a gray line there in terms of the different types of skin cancers and the risk factors that contribute to that. So basal cell and squamous cell are the most common types of skin cancer overall, and they're the most common cancer overall in general. So it accounts for more than 5 million cases every year of cancer in general. So that's the bulk of the type of skin cancers that we're seeing on a regular basis, and they are fairly common in our practice. So with basal cells and squamous cells, we know that the biggest contributing factor is definitely UV radiation, the damage to the skin that's done over a person's lifetime. But certainly family history, personal history of chronic cumulative sun exposure, blistering sunburns, a very moldy person, or a lot of freckles. These are all things that need to be taken into account because they certainly add up in terms of risk factors for potentially developing another skin cancer in the future or being at risk for just developing the first skin cancer. Melanoma being the least common skin cancer, but definitely the most deadly skin cancer. Has UV radiation as one of the most common contributing factors to that, but has a lot of other factors that contribute as well. Family history, skin type, like you said, red hair, light skin, light eyes, having what we call atypical nevi or multiple moles that kind of have a funny appearance to them. There are a lot of different things that can contribute to that pattern on a person's skin, but we look at those things as well because that certainly puts someone in a different category of where we might think, yes, this person is at an increased risk for potentially developing melanoma over time.
Okay, so you mentioned the basal cell and the squamous cell. Those are relatively benign usually, or they can turn to something else?
Right. In most cases, so basal cells are very, very indolent, slow-growing skin cancer. So we really don't think about basal cells when caught early or even caught in between stages as being super aggressive tumors in terms of metastasis or spread throughout the body.
Okay.
However, a basal cell or a squamous cell left untreated can certainly grow locally, can invade, can cause a lot of tissue damage or morbidity issues for the patient if left untreated. So when they are caught and treated adequately, the cure rates are over 98 to 99% for basal cells and squamous cells. So we don't think of them as, in most cases, deadly tumors. However, they can cause a lot of issues for patients left untreated. Melanomas are the ones that, though they account for only about 1% to 2% of the skin cancer, they are the most deadly, and rates of melanoma continue to increase every single year.
Okay. Yeah, so they're the ones that can they can metastasize and spread to other organs, and if not detected or treated.
Right.
So what's the diagnostic tools that you use to determine, obviously you're looking at it first, but then what do you do to determine the cell type?
Sure. So there's still nothing better than clinical examination. So the importance that we try to stress to our patients with skin exams is coming to be seen for skin exams if you have those risk factors or a history of skin cancer, but home skin exams are extremely important because a lot of our patients come in and they're the one that has detected their own skin cancer.
Yeah.
They notice a change, or their wife or husband has told them that there's a black spot on your back that wasn't there. That's really, really important to be able to at least follow your own spots at home, not necessarily know the exact sizes or the exact colors, but to notice a change, to be able to come in and tell us that something has happened in the time that we're not seeing them. And in terms of diagnostic tools that we use outside of clinical examination, we use biopsies, we use dermoscopy, we use photography. So biopsies are the objective way to get a piece of tissue, send it off for pathology review, to look at underneath the microscope and determine the type of skin cancer. You can tell a lot from a biopsy. You can tell the depth of a lesion, which is extremely important with melanoma. You can also tell if there are certain other concerning factors about a tumor on biopsies, such as if they're around nerves or more aggressive features to them. So that's
you would
important.
need that you would need to do the biopsy to determine the cell type, or you already know that based on
Exactly. There are a lot of clinical features that are very classic for a basal cell or squamous cell or melanoma. So you can oftentimes see them before you do a biopsy, but you want to have that biopsy determine the exact type of skin cancer, and then there are subtypes within those skin cancers that determine treatment and outcome as well. So it's very important to have the biopsy.
Is there a recommended, I know when you turn 50 you should have your first colonoscopy. Is there a recommended age that the Academy says people should be screened?
Unfortunately not.
No, okay.
There hasn't been any consensus through them or the American Cancer Society, anybody yet, to determine or give that right or perfect age, which is why we see a lot of children for baseline skin exams. We see a lot of adolescents or young adults for baseline skin exams. There is probably not a lot of high yield to doing skin exams on a young person on a yearly basis because their risk factors are still relatively low. But that's why we see people, because we talk about risk factors, family history, other things that could determine how frequently they need to be seen. So most people that we see in our practice, or a lot of them, have history of precancerous or cancerous lesions. So that helps us to determine that we know we're going to be seeing them at least yearly, if not every 6 months, or even a little bit more frequently for higher risk skin cancers.
Okay.
But then we also have regular people who have never had a skin cancer before, but who tell me, I went to tanning beds my whole life, or I worked on a boat my whole life. So they have significant sun damage, which still adds risk factors to potential for them to have skin cancers in the future, and we will see them for yearly skin exams as well.
Besides the sun, is there any other serious risk factors, smoking or anything else that would be a major contributor to skin
Tanning
cancer?
bed use has really come into the forefront as being a known carcinogenic factor for contributing to skin cancers. A lot of studies that have come out over the past several years show that it increases your risks for all three of the most common skin cancers. But the concerning thing is melanoma, obviously, because melanoma rates continue to go up. But the number of people dying from them is not changing, even though we're better at detecting melanomas. So the rates for young people, specifically melanomas, have doubled over the past 20 years under the age of 45, and specifically in women, young women. So we believe that this is directly attributable, or a large proportion is coming from tanning bed use and high-risk sun behaviors, tanning in regular sunlight, but also tanning in tanning beds. We really try to get that point out to people. I have a lot of patients who have come to me, and especially in this area, being at the beach, that they've not only do regular tanning at the beach, but tanning beds, before proms or, before big events. And even just a few episodes of tanning bed use can significantly increase your risk for developing skin cancers in the future.
Okay, so now you're diagnosed with a skin cancer, hopefully not a melanoma. What's the treatment for these things?
So it really varies based on skin cancer type or tumor type, and then the subtypes within. So for basal cells and squamous cells, it really depends on location, the size of the tumor. Surgical procedures are very commonly used, either surgical excision where the tumor is taken out, all done under local anesthesia, and then the skin is closed, and that gives very high clearance rates. We also use a special skin cancer surgery called Mohs surgery, which is performed by specially fellowship-trained dermatologists who specialize in higher risk skin cancers, higher risk areas, more aggressive features of skin cancers. But then there are a lot of other methods that are non-surgical, topical chemotherapeutics we use to treat certain types of skin cancers. Something called electrodesiccation and curettage, which is scraping and burning of lesions. And then we also use liquid nitrogen or cryotherapy, and also a light treatment to treat more of the precancerous side of lesions. So surgical excision and surgical treatments are probably most commonly used, but again, it depends on the type of skin cancer and the location and the size.
So when you talk about type and size, is there staging as well with skin cancers like other tumors in the body?
So there is staging that is done for squamous cells more commonly, and melanoma the most common. It's not commonly used, at least for basal cells and squamous cells, for the average tumor and for the average person. Melanoma, it is very important because that deals with prognosis, that deals with if any recommended extra treatments are needed, such as oncologist follow-up or further imaging. So with basal cells and squamous cells, standardly we don't stage them unless we find high-risk factors on the size or on the biopsy. But melanoma, it's very important to stage because that really prognosticates how that person will do over a 5-year, 10-year, 15-year period.
Got it. So now we know what the treatment is. What's the prevention for this? Obviously, staying out of the sun where possible. Tanning beds are no. I know some of the teenage girls now are doing the spray tanning, which is much better, obviously.
Right. And
so what is some of the really good prevention tips for the skin cancer?
Sure. So from a sun protection standpoint, protecting from the sun is number one for any of the skin cancers. So sun avoidance is the best because you're not getting that UV radiation, but we know that people are going to be going out, and we don't want to prevent people from living their lives and enjoying things. So when you're out, there are a lot of sun protective clothing that is made that has what's a UPF level, which actually has a built-in block against sun.
Oh, okay.
So that helps, wearing those protective types of clothing when you're going to be out in those midday hours. Sunscreen is extremely important, and you want to be at a certain SPF when you're using sunscreen. So sunscreen at the minimum of 30 is really good, and you'll get a little bit of incremental benefit as you go up in the SPF number. Not much above about a 50 or so, but sunscreen is extremely important, and using the right types of ingredients. So the average person will usually put sunscreen on, but they don't reapply or they don't put on enough. So for sunscreen specifically, you should be using the way that it was tested to verify that that is the SPF level that someone will be getting, is about a heaping shot glass is what someone should put on every time they coat their body, which is not what most people will do. So if you keep a whole bottle of sunscreen for the summer, you definitely didn't use enough. You should be going through a little bit more than that. So a heaping shot glass of sunscreen is really what should be meant for the whole body. And we think about that general rule of those midday hours of trying to do sun avoidance or covering up and using a lot of sunscreen. So if your shadow is shorter than how tall you are, then you really are in those midday peak hours, and you want to be doing all of those things for protection.
Great. Okay, so we heard about the various types of skin cancers and the prevention. When we come back, we're going to hear about several different skin diseases and maybe some cosmetic features as well that can be done in the dermatology field.
Drop that baby.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our guest today is Dr. Sarah Cannon. Dr. Cannon is a board-certified dermatologist, and she practices at the Dermatology and Skincare Center in Red Bank. Dr. Cannon, welcome back. So when we finished the first segment, we talked about several different skin cancers, and you mentioned prevention. Question we had during the break was, is there a difference between the aerosol skin lotions versus the regular kind of creamy lotion?
Sure. So in terms of active ingredients, which kind of becomes important at this point, zinc oxide and titanium dioxide are the only two physical blockers or mineral sunblocks. Those are really the active ingredients that you want to be looking for in sunscreens. And the difference with the aerosolized products is really usually they are the chemical sunscreens. So though you're going to still get the SPF that it has on the bottle, broad spectrum coverage is really best with physical blockers of the two, either zinc oxide or titanium dioxide. So I usually recommend my patients to stick with those as the active ingredient. Brands are really not as important to me. It's the active ingredient and the SPF number. So at the minimum of a 30 and being zinc oxide and or titanium dioxide.
And the importance of reapplying.
Exactly. Reapplication should be at the minimum every 2 hours, but if you're sweating, if you're working out, if you're swimming, it should go right back on.
Great. Okay, let's talk about some of the other common skin disorders and treatment options. Teenage acne or adult acne is very common. What is acne and what do you do for it these days?
Sure. So acne is one of those conditions that is multifactorial. So there is nothing that you can see when a person comes in and say, you have this one type of acne. We can look at the type of outbreaks you have, the symptoms that are associated with it, and the types of pimples, things like that. But it has multiple contributing factors. So there's bacterial buildup, there's clogged pores, there's the inflammatory response to all of that's happening inside the pores, and then hormones become a big factor as well. So we take all of these things into account when we look at a person's skin, when we look at the types of flares and the types of breakouts that they actually get, and symptoms over time, if it flares with certain times of the month or certain times of the year, things like that. So you have to take all of those things into account because medications are geared towards those different parts of acne.
And what is the most common, do you use antibacterials or what are the medications that you use?
Sure. So in terms of topicals, we use a lot of topical antibiotics and topical antibacterials, and then also retinoids. So retinoids are like retin-A type products. They help with normalization of the way skin grows. They help with declogging of pores, acne scarring, and things like that. So they are really good as a basis for prevention and maintenance of any type of acne, really. And then topical antibiotics like benzoyl peroxide, things like that, they really help with the inflammatory pimples, with bacterial buildup, with inflammation. And then we also use oral antibiotics. Oral antibiotics are not a long-term solution for any acne patient because of side effect profile that's associated with it. However, it can really, really help and make a big difference in the short term for calming down people who have very inflammatory acne or a lot of bacterial buildup that is associated with their type of acne.
And what about things like moles and warts? Are they just common and you make sure they're nothing bad and you remove them, or can there be something more associated with them?
Sure. So moles are extremely common. We start to see them for the majority of people developing young, in children, adolescents, and we usually will stop seeing people developing new moles in late 20s, maybe mid 30s or so. You can certainly see moles changing over time, but there's no recommendation that if you have a mole and it appears benign on clinical examination and on history from the patient that there hasn't been any changes to it, that it has to be removed. That really doesn't change a person's skin cancer risk because the majority of skin cancers will arise from normal skin anyway. So as long as moles on clinical examination appear benign and the history shows that they're not changing, they're not bleeding, they're not growing, we leave them alone and we just continue to monitor them.
Okay. Eczema. What is eczema and how do you diagnose it and treat it?
Sure. So eczema is a very general term for dry, itchy, flaky skin. There's a lot of subheadings that come under eczema, but one of the most common is atopic dermatitis. So that is the itchy, rashy skin that you'll see most commonly presents in young children, and that can be associated over time with a child developing asthma or allergic rhinitis or allergies. We diagnose it based on the way that it looks, the pattern. Eczema or atopic dermatitis in children and young adults is very, very itchy, so we really think about that more as the itch that rashes. So very sensitive skin, and a lot of what goes into eczema or atopic dermatitis, like acne, is very multifactorial. We know that atopic dermatitis children or patients have a defect in the barrier in their skin, so their skin breaks down a lot easier. They take on a lot more allergens, so they're sensitive to many other things that the average skin wouldn't be. They have an increased risk for getting infections there, and they're very, very itchy. So we try to manage all of those symptoms, and oftentimes you end up using topical steroids, topical anti-inflammatories to calm the skin down, sometimes antibiotics to controlling infections that might come on top of that, because people are very, very itchy with that condition. So that's how we treat that.
Okay, psoriasis, what is that?
So psoriasis too, as you can see a pattern with a lot of skin diseases in dermatology, is multifactorial as well. Psoriasis is a big genetic component to it. We see it in young children definitely, but there is a peak in around the 20s to 30s, and then also a peak around the 50s for people. So those are kind of when we're seeing waves of new cases of psoriasis. So psoriasis, like eczema, is not necessarily something that you cure. It can get better over time, and we control it. It's a really exciting and great time for psoriasis if you do have psoriasis, because there are a lot of new medications that have hit the market recently. So classically, it has been topical steroids, topical anti-inflammatories. We use light treatment as well, but there are a lot of new injectable medications which are in the immunosuppressant family of medications, and researchers have figured out the pathways that lead to psoriasis and have been able to really target the mechanisms behind it. So a lot of the new medications that are out on the market now are injectable medications, and they really have great clearance rates for psoriasis for control over time.
Now, if somebody just has dry skin, and they treated with some topical moisturizer, it doesn't necessarily mean there's a medical problem there, correct?
Right.
When does it become something that needs to be assessed and diagnosed as something further?
Sure. In terms of good dry skin care, we want everyone to be moisturizing, and if the skin is breaking down, we do a lot of dry skin care techniques, such as not taking super hot showers, using emollients like ointments are better than creams, which are better than lotions. And when the skin doesn't respond to good things like that at home, then that's when we really want to step in, because you don't want the skin to be constantly breaking down. You have risk for more infections, for thickening of the skin, and for more longevity of the lesions. So really, when you're not responding to typical things like that at home, just taking good care of your skin and moisturizing, and there's plaques that are just always present, those are times when we can help. And that's when you can use more prescription strength, stronger topical medications to help control those outbreaks. And oftentimes for people, it does resolve over time. It might be an allergen to something that they're coming in contact with in their skin, or maybe they're taking very hot showers and using a lot of irritating products. And these are all things that we can go through with patients to help target what exactly might be causing it. Sometimes it's just a genetic disease, but sometimes it's external factors too.
Got it. Now, a lot of people don't think of the hair as something associated with the skin. So hair loss, is that something you deal with in dermatology? And what are some of the options these days for hair loss?
Sure. So we deal a lot with that. That is probably one of the most concerning diseases that people come in for, because it's very scary for people when they start to see hair loss. So with that, you have to really do a good assessment of the hair loss that the person is experiencing. Is it bald patches? Is it scarring? Is it just thinning of the hair? Is it a lot of loss? So that helps us to kind of divide out the type of hair loss that it could potentially be, scarring or non-scarring. And then with non-scarring hair loss, there are a lot of different hair diseases. Some of them are autoimmune in nature. Some of them are related to genetics or hormonal imbalances, sometimes even underlying medical conditions like an undiagnosed thyroid disease or anemia or low blood count. So we take all of those factors into account. We assess the hair. Sometimes biopsies are needed to actually look at the hair follicles and the hair itself. And that really helps to guide us in terms of which direction we can go and which direction we can treat. One of the most common things we see is androgenetic alopecia, genetic or age-related hair loss that sometimes is related to hormonal imbalance. And we use topicals such as Rogaine or Minoxidil. We use oral medications that help to deal with hormonal imbalances that could be contributing to that. And there are some new procedures that are out now, something called PRP, which uses a patient's own plasma to help stimulate growth and give growth factors back to the scalp. So that's one of the newer and up-and-coming treatments that has had some good benefit in combination with other treatments for at least one of the most common types of hair loss.
That's interesting. So you use, I mean, in PRP, in the sports medicine orthopedic world, you know, I know of, but you're using it for hair follicles as well, to stimulate hair follicles?
Right.
So would you do that in patches, or you do it in large areas? Or?
You can do it in large areas.
Wow.
And for female pattern hair loss or male pattern hair loss, oftentimes people are coming in and they're just starting to notice it, and they're trying to want to be on top of things before it progresses. So you're targeting certain areas that are losing the most. Oftentimes for androgenetic alopecia or these female pattern or male pattern hair losses, the hair stays very thick at the back of the head for a long time. So you're able to target certain areas. It's done over a series of treatments, and it takes multiple times, but you can definitely see improvement over time with the injections.
Now you mentioned the Rogaines and Minoxidils. Are there any side effects of those products, and are they just topically applied, or is it oral? How is the
Right, so
treatment?
Minoxidil has been around for a very long time. It's topically applied, and the solutions now are all the same percentage for both for men and women, and we have people use them on a daily basis. And what goes into Minoxidil treatment is that oftentimes you're going to see a loss of hair in the beginning because it really recycles the way that the hair is growing. So sometimes people get discouraged at that time period because they think it's not working or it's worsening things, and we tell people to really push through with that. Side effects that you can see with Minoxidil are occasionally local irritation to where you're applying the product, but we are definitely want to tell patients that when they're using that medication, especially for women, that you have to just be careful where you're applying it because it's stimulating hair growth. You don't want to be putting it at other locations on the face. But it's a very well-tolerated medication. It just takes a long time, just like the cycle of a hair and growth of a hair takes a long time. You have to stick with it. I usually have patients at the minimum use it for 8 to 12 months before we say that it's a potential failure.
Okay. Now, there's some exciting new cosmetic procedures that you can do these days for various conditions. Botox is very common. Can you just explain the process of Botox and where do people typically use that?
Sure. So Botox is most commonly used for upper face dynamic movement lines. So lines that happen with facial expression, not necessarily at rest, but that happen when a person moves their face and moves the upper muscles of the face. So Botox is used for paralysis of muscles. And it sounds a little bit crazy at first, but in targeted doses to correct muscles and in specific locations, you're able to knock out movement or at least decrease or blunt movement in certain locations to help with lines, fine lines and wrinkles that happen with movement. So forehead, in between the eyes, or what we call the glabella, and around the eyes are probably the most common locations that we use Botox to help smooth fine lines and wrinkles. And we also have generalized it. We use it in a lot of other locations on the face for very specific muscle movement, sometimes for lines around the mouth or certain locations to the sides of the mouth as well for certain lines there. So it really depends on what bothers a person. So when we see them, we assess them, and it's a series of injections of very small needles that are used to deposit the product into those areas. And it works very well. It can last for up to 6 months for many people.
Great. I know there's one new product out, Kybella. It's used for the kind of that puffy chin look.
Right.
And can you just explain that?
Sure. So
process?
Kybella deoxycholic acid, it's a bile acid, and what it does is it actually degrades fat, and to a semi-permanent and permanent degree. So it's only indicated for submental fat. So that thickening that many people hate underneath their neck.
The double chin look.
Exactly, which can be, over time weight related or even genetic related. Some people just have a fullness underneath their chin that, they do everything they can to work out and to eat right and exercise, and they just can't seem to get rid of that. So Kybella is a great product for that area. So it again is a series of injections where you inject the Kybella molecule into this area, and it slowly over time will degrade the fat. The injections are done on about a monthly basis or so. And what you find after a series of injections is that you slowly start to lose the amount of fat that's there. Your angle underneath your neck becomes a little bit more, acute and tighter, and it really helps with that area.
Awesome. Dr. Cannon, thanks for joining us on the show. Really appreciate it.
Thank you so much for having me.
So you've been listening to You and Your Health, where we talked about dermatology and various different skin types. I'm your host, Dr. David Bertone. Until next time, we'll see you on You and Your Health.